Hello, my name is Taylor Clark, and my group members' names are Giuliani and Sydney. We were assigned the case study of eating disorder, and this is for our class Counseling 6310, Clinical Psychopathology with Dr. Catherine Pang. The background consists of Joanne, who was a 38-year-old woman with a good job and family life. She lived with her second husband, Mitch, and her 16-year-old son, Charlie, from her first marriage, and her husband's 18-year-old daughter from a previous marriage. Joanne was employed as a secretary at a university, and Mitch was a temporary federal employee. Joanne was 5 foot 3 inches and weighed approximately 125 pounds. Although she was concerned about her weight, her current attitudes and behaviors were much healthier than they had been a few years earlier when she had been diagnosed with anorexia nervosa. Joanne had struggled with a serious eating disorder between the ages of 29 and 34. She was eventually hospitalized for 30 days. The treatment she received during that hospital stay finally helped her overcome her eating disorder. 4 years later, her condition continued to be much improved. Her continued background, we're going to go over some social history. Joanne came from an ordinary family consisted of a father, mother, younger brother, and her. When Joanne was 14 years old, her brother was ran over by a car under her care. This caused her to feel guilty for years after his passing. As a result, Joanne's parents became extremely overprotective of her, which resulted in Joanne getting married at the age of 19. Her marriage lasted approximately 6 years, and they had a child, Charlie. During her pregnancy, Joanne gained 200 pounds and then lost around 60 pounds. Once her divorce was finalized at the age of 25, she had to move back to her parents, which was stressful for her as her parents continued being overprotective and taking the role of caregivers. She felt as if she was the older sister of Charlie and not his mother. Joanne and Charlie were involved in a car accident. Joanne required multiple knee surgeries and therefore physical therapy. During this time, Joanne weighed approximately 110 pounds due to not having an appetite and being nauseated. She then met Jack and quickly moved in with him. Jack was a heavy drinker, and eventually Joanne became one too. Over time, she realized that this behavior was not healthy for her son and ended the relationship. The onset of her eating disorder will be discussed in this slide. When she was 29 years old, nearly 3 years after her accident, Joanne returned to the hospital for additional surgery on her leg. After being discharged, she began to diet. Joanne's eating problems persisted for the next 5 years. During this period, her weight fluctuated between 90 and 105 pounds. At times, she ate more normally, but then she would eat practically nothing for months. When she was 32 years old, almost 3 years after the onset of her eating problems, Joanne met Mitch at a church gathering, and they began dating. Mitch seemed to help Joanne feel differently about herself. They frequently talked about her weight and how little she ate. Mitch expressed great concern about her health, gently pleading with her to gain weight. 1 year after she started dating Mitch, Joanne needed major abdominal surgery to remove 2 cysts from her small intestine. Following the surgery, Joanne gained some weight, but soon resumed her restrictive eating patterns. It was then that Mitch and her friends encouraged her to seek help, and Joanne had herself committed to a 30-day treatment center at the psych ward. The first case question that was in our book said, what special challenges does anorexia nervosa pose for family relationships? How does it affect patients and their roles as children, spouses, and parents? Attachment theory accepts that early relationships with caregivers form the foundation for future social and emotional development. People with anorexia nervosa often experience insecure attachments during childhood, which can manifest as difficulty trusting others and forming close relationships. These early attachment experiences can affect their interactions with family and children. For the families themselves, having a family member with anorexia nervosa can be extremely challenging. Schwartz 2015 states family members may experience heightened stress, emotional stress, and a sense of helplessness as they grapple with the challenges of supporting a loved one with anorexia. For mothers with anorexia nervosa, insecure attachments may contribute to challenges in recognizing and responding to their infant's cues, potentially leading to difficulties in forming a secure bond with their child. This lack of secure attachment can perpetuate social isolation and can contribute to mental health challenges, such as an increased risk for suicidal thoughts and behaviors. Case question number 2. What does anorexia nervosa have in common with substance abuse disorders? Anorexia nervosa and substance abuse disorders have several things in common, including comorbidity with other mental illnesses, physical harm done to the body as the disorder progresses, and the challenge faced not only by the individual, but for the families as well. According to Barbaric, Marsteller, and Fulton and Walsh, from a clinical perspective, individuals with anorexia nervosa behave similarly to individuals with substance abuse by narrowing their behavioral repertoire so that weight loss, restricting food intake, and excessive exercise interfere with other activities in much the same way that substance abuse does. A continued take for substance abuse and anorexia and their similarities. These include extreme preoccupation and compulsive behavior, cravings, rituals, and secretiveness around the behavior, mood-altering effects, social isolation, and a need for intensive therapy and comorbidity with other psychiatric disorders. Substance use disorders are incredibly common in those with eating disorder diagnosis, with 27% of those with anorexia nervosa. These disorders often feed off of one another, with one study determining that women with an eating disorder or substance abuse disorder were more than 4 times as likely to develop the other disorder as those women that experienced neither disorder. People often use substances and/or eating disorders behaviors to help them cope, and therefore those struggling are likely to engage in one or both disorders. And as you can see, there is a graph over here that explains eating disorders and substance use disorders. 50% of people with eating disorders use substances or alcohol, and 35% of people with a substance use disorder also have an eating disorder. Case number 3 question. Much research has focused on the role of the media and standards of beauty and the thin ideal and the etiology of anorexia nervosa. Do you think these factors are improving or worsening? Is there more or less pressure on the adolescent girls and young adult women today to be thin? What about pressures for attractiveness on adolescent boys and young men? These factors are improving as the desired body type has changed from thin to an hourglass figure that depicts thickness and curves. The same body type is actually shaped for males and is less than from what it used to be. Less pressure is on adolescent males and females to be thin. Adolescent boys and young men's attractiveness is promoted from a softer look rather than a stark or defined look. Beauty standards have transformed from extremely thin to slim, thick body types. The demands we put on women, young girls, and males have not changed per beauty standards. These standards are demanding and promote control over happiness and represent today's perfection. It is important to consider that the standard is not thin, it is still promoting personal perfection of the most desired look. Case number 4 question. No treatments have consistently been shown effective with adults with anorexia nervosa. If you were a psychologist treating a college student with the disorder, what treatment approach would you use and why? I would offer that the client see a nutritionist as well as a cognitive behavioral therapist. Setting goals for eating while using psychoeducation can be effective for clients with anorexia nervosa. Using a food diary for daily consumptions can be helpful for the therapist and the client to go over during sessions. Also, thought patterns and those types of diaries. By measuring anxiety related to consumption, the therapist can use an active CBT tool to encourage the client to challenge himself or herself during unhealthy thinking patterns before consumption of food and beverages. And here is a graph of how CBT kind of works and the theory in a picture. The case summary of Joanne consists of Joanne met the diagnostic criteria for anorexia nervosa, binge eating, purging type. She experienced a drastic self-induced loss of weight, was intensely afraid of becoming fat, and was unable to recognizing the true size of her body of the seriousness of her condition. Number 2, she experienced many of the physical side effects that accompany starvation, such as loss of menstruation, skin changes, constipation, hypotension, bloating, abdominal pains, dehydration, and lanugo. Number 3, hospitalization is usually the first step on the treatment of anorexia nervosa to target healthy weight for the patient. Number 4, the implementation of cognitive therapy to challenge her views on the world involves several steps: learning to be more aware of her thoughts and beliefs, exploring and clarifying the connection between dysfunctional beliefs and maladaptive behaviors, examining the truth of those beliefs, learning to replace dysfunctional beliefs with more realistic ones, and eventually changing the underlying assumption that are creating this dysfunctional beliefs. Number 5, Joanne had a strong support system and had reached maturity, which are factors that might have possibly impacted her outcome. Thank you for listening, and here are our references.